Hi, good morning. We can start if everybody's here.
Good morning, doctor. My name is Hazmi Hisham.
Yeah, we can start.
I'll be the first presenter for topic ECG. Okay. Next slide. Okay, so ECG or electrocardiogram.
Got echo lah.
Echo.
I think you have to off on the devices, I think.
Is it okay now?
Yeah, it's better now.
Okay. So in ECG, as we know, there is 12 LEDs, 6 dim LEDs placed on the arm and legs, known as LED 1, 2, 3, FVL, FVF, and also FVR. And we also have 6 precordial LEDs, which are placed on the torso, known as V1, V2, until V6. Next slide. So these are the indications for ECG. We do ECG in patient with syncope, chest pain, SOB, arrhythmia, in patient with symptom of Kawasaki disease, rheumatic fever, or patient with congenital heart disease, any patient with electrolyte abnormalities, or patient with seizure. For contraindication, there is almost no contraindication except if the patient themselves refuse the procedure. Next. So these are among the complications that can occur in ECG, which is mild rash or skin irritation, which can cause due to contact dermatitis, either to the gel or the metal itself. Next. So these are the equipments that we need to prepare before we want to perform ECG. First, we have to have the ECG machine itself, the ECG paper, the electrodes, the alcohol rub to clean the skin before we put the gel and the sticker. And then we have to have the skin preparation equipment such as the ECG gel and the cleaning wipes. After we done the ECG, we have to clean the patient's body. Next. So the methods for ECG is first we prepare the equipment. Second, we introduce, explain procedure, and we get verbal consent. And then we wash or we sanitize our hand, and then we prepare the patient. First of all, we must ask the patient if there is any metal, jewelry, or any skin, if he or the patient is wearing any skin cream. Then we ask the patient politely to remove his or her clothing, and then we ask the patient to lie supine on the bed. And then we place the electrode accordingly, and then we enter the patient's demographic detail on the machine, such as the name, gender, time taken, and then we start the ECG. And then after we start the ECG, we wait until the graph stabilize, and then we print out when we are satisfied with the ECG, and then we remove the electrodes and wipe the skin. And it is important in pediatric to make sure that the infant and child to be calm during the procedure, or else it can interfere with the result. Next. So these are the lab testament for ECG. So for pediatric, there are unique lab, which is V4R. So V4R, we place it on the same side as before, but it's on the right side of the chest. We do this because in children, sometimes the right ventricle might extend beyond the right sternum. So for V1, as usual, we put it at fourth intercostal space, right sternum border. For V2, we place it fourth intercostal space, but left sternum border. For V3, it is midway between V2 and V3. Usually in the adult, it will be at fifth intercostal midclavicular. So for V4R, it is at fifth intercostal midclavicular line. And if we use V4R, we must label on ECG. For V5, it is at anterior axillary line, same horizontal plane as V4. And for V6, mid-axillary line, same horizontal plane as V4. For limblets, we place on top part of arm or legs to make sure that there is less muscle interference. Next. So this is the video for pediatric ECG. I think there is no sound. Cannot hear the sound.
Hazmi, you have to share the video, share the sound at the top.
Okay.
The options there, you have to share the sound.
Because it's not me the who present.
Siapa yang ni? Siapa yang
Sorry, Doctor. What did you say just now?
you have to share the sound, Anis.
Okay.
Yes.
Thank you. And do you have anything in your pockets? Any cell phones, any keys? Thank you very much. Okay, go ahead and lie down for me. You're gonna put your arms at your side. So before I put your EKG stickers on, I'm gonna clean your skin off with just a little bit of alcohol. Just where all of your stickers are. I'm going to be putting your EKG stickers on now, okay? Okay, you take a right arm. And I'm going to do your left arm. And then I'm going to do your right leg. And I'll lift up your pant leg. And I'm going to be doing now your left leg. Okay. Now I'm going to start putting the EKG stickers on your chest. You can put your arm down. Okay, and that's the placement of all your stickers. Okay. So now I'm going to connect the wires to your EKG stickers, okay? Stretch them across. And I'm going to connect your right arm and your right leg, making sure that your right arm is your right arm. And your right leg is your right leg. And now I'm going to do your left arm and your left leg, making sure your left is your left. Now I'm going to put them on your chest. Lift up your arm for me. They're all on. I just need you to lie nice and still. Okay, we're ready to do your EKG. The EKG is now pregnant. So here's your EKG. We're all finished, and I'm gonna go show this to your doctor, and you'll just wait for the results. Okay. Okay. And now I'm gonna take off your lead wires, okay?
I think that's all from me. Thank you.
Okay. Next, no, if no questions, then next one.
Sorry, I think you
All right, who's supposed to be presenting?
Anis.
Hello.
Anis.
Hello.
Okay.
Okay, sorry, doctor. So as I said before, I'll be presenting about bone marrow aspiration and treatment biopsy. So it is basically a test usually to diagnose and staging of hematological disease, as well as in the assessment of overall bone marrow cellularity. And there are several indications for this test. It is usually done if there is to do evaluation of unexplained anemia, leukopenia, thrombocytopenia, or even pancytopenia, or if there is unexplained polycythemia, thrombocytosis, or leukocytosis. So basically, there is a decrease or raised in the cell numbers, or if there is unexplained splenomegaly in the patient, and also unexplained fever or fever of unknown origin. And then it is also done for evaluation of iron metabolism and stores. If there is a suspected deposition and storage disease, for example, amyloidosis, if there is a suspected mycobacterial, fungal, or parasitic infection, or granulomatous disease. Granulomatous disease is genetic disorder where the phagocytes are unable to kill certain types of bacteria or fungi. So yeah, to look at the cells activity if there is a problem, or even done for normal marrow confirmation for potential donor to look at the marrow if it is healthy or not to be donated. And then it is also done to diagnose lymphoma or other solid tumors, and of course leukemias. So contraindications for this test, there are a few absolute contraindications. The first one is severe hemophilia, where if the patient's clotting factor is less than 1%, if the patient has severe DIC, okay, basically those are the two absolute contraindications. But it should also be noted that sternum should not be used, should never be used as a site for biopsy, but can for aspiration only, but actually only in adults. So in children, we still don't use sternum as a site. But again, I'll explain later more. And then, okay, for thrombocytopenia, it is actually not a contraindication. However, prior to doing this test, we need to do full blood count and even full blood picture to ensure that the patient's platelet is at least more than 20. Yeah, and then we can do the BMAT. Yes, if not, then maybe platelet transfusion may be required for the patient if it is less than 20. And then for relative contraindications, of course, there is skin infection or osteomyelitis on the targeted site, or patient are unable to remain still. Yes, but it's relative. So we, for the patient unable to remain still, we try our best to keep the patient calm and keep them still. Okay, for preparation, first we need to decide for the specific patient which tests are needed. For example, not all patients need both aspiration and biopsy. So some patient may only need aspiration only. For example, in if to look for progression of the disease, for example, leukemia. So maybe biopsy is only needed in the beginning to diagnose the disease. And then timing of procedure. It is actually best to do the procedure on the same day we receive the full blood count and full blood picture. But however, I don't know. I'm not sure in Malaysia or in SASMAC able to do this, because usually patients have appointment later to do bone marrow aspiration and biopsy. And then a choice of site. So
what did you just say?
I read that it is best to do the bone marrow aspiration and biopsy on the same day we took the full blood count and full blood picture, because to look at the exact same like cellular status of the day.
It depends on where. It depends on how and how do you say this? It depends on when and how the patient was admitted. Because if it's like an emergency thingy, well, yes, bone marrow is by appointment, but then it's like if the child gets admitted and then you think it's leukemia, right? And then usually what happens is that the full blood picture that's taken first, and then sometimes you can see the cells, and after that the appointment is made. So usually in those kind of semi-emergency cases, the appointment is very much early. It's within 1 or 2 days. The next day is what can do. So it's basically doing at the same time also lah. Understand?
Okay, thank you, doctor. And then, of course, we need to determine the choice of site to do the aspiration and biopsy. So for pediatric patient, there are 3 options. Actually, just 3 options. But the most common one used is posterior iliac crest. And for tibia, it's only done in infant. So sternum in adult, another choice is sternum, but in pediatrics, it is contraindicated. So mostly we'll choose posterior iliac crest as the site. And then pre-medication, we can give the patient lorazepam for to reduce anxiety and also for anti-grade amnesia for the patient. I also read that in pediatric patient that we will use general anesthesia, but again, I'm not sure if that is for all patients or just.
It depends. It depends on where. It depends on the center that you're working at. Usually in government hospitals, we tend not to use general anesthesia. You're more likely to see it being used in the private sector. Also, in pediatrics, we don't use lorazepam. We use a combination of midazolam and it depends on the children's age lah. But we don't tend to use lorazepam. Okay.
Okay. Okay. Okay. And then next, of course, we need to prepare the equipments. So first, we need to need antiseptic solution, lidocaine, syringe, needle, scalpel blade number 11, aspiration and biopsy needle, of course, and then gauze, glove, sterile glove, EDTA vial, and also formalin solution to put in the biopsy tissue later. So there are actually a few types of needle. Yes, but I think the most popular one is called Jamshidi needle, which is this one, the blue one. This is if it comes in a set like this. Okay. Okay, so the techniques, these are the techniques. I think it's best to watch the video first.
Video describing the process involved in taking a sample of bone marrow. Often, diseases of the blood can only be correctly diagnosed after morphological examination of a bone marrow specimen. The sample can be obtained by needle aspiration from the medullary cavity. In adults, the sites for aspiration are the first part of the body of the sternum and the anterior iliac crest and the posterior iliac crest. In children, the anterior and the posterior iliac crests can be used, and in infants, we also use the upper medial aspect of the tibia. The preferred site in both adults and children is the posterior superior iliac spine. A specially designed needle is used. This has a well-fitting stylet and an adjustable guard. First, the overlying skin is cleaned. Then the skin, subcutaneous tissue, and periosteum overlying the site selected for the puncture are carefully infiltrated with local anesthetic, such as lignocaine.
Okay. Did you feel anything there at all? No. Apart from my fingers?
With a boring movement, the needle is passed perpendicularly into the cavity of the ileum.
You're there, you'll feel a sharp tug, the toothache tug I was talking about, okay?
The stylet is removed, and then, with a well-fitting syringe, about 0.3 mils of bone marrow is withdrawn.
Okay, the needle's coming. Okay.
The sample of bone marrow is spread onto microscopy slides ready for staining and structural examination of the cells by microscopy. 7 or 8 slides are prepared. In addition to morphological examination being performed here, further samples of bone marrow can be taken for chromosome analysis, immunophenotyping of cell markers, and culture for microorganisms.
Going to do the second bit, okay? Okay.
Sometimes a histological section is required. This allows a complete assessment of marrow architecture and of the pattern of distribution of any abnormal infiltrate. Core biopsies are obtained with a trephine needle. The same skin puncture can be used, but an adjacent site in the bone is chosen. Again, the periosteum is infiltrated with local anesthetic. The procedure is more painful for the patient, but is particularly useful when investigating bone marrow infiltration, fibrosis, or aplastic anemia.
Okay, the needle's there, okay?
The bone marrow aspiration and trephine biopsy is carried out as a day case, and the patient usually only requires 20 minutes rest before going home.
Okay, so just to recap what the video has shown. So of course, first we need to position the patient. Usually we use a lateral decubitus position, but in pediatric, they also in prone position as well, usually. And then we need to examine the site, of course, if there's any infection, and then palpate the posterior iliac crest. Okay, this I'm talking about if we are doing it on the posterior iliac crest. So we need to palpate the posterior iliac crest, make sure where it is. But we need to also palpate anterior iliac crest, because it'll be helpful later. Because okay, and then at the chosen mark, it is usually 3 finger breadth from the midline and 2 finger breadth inferior to the iliac crest that we have palpated just now. And then of course, don yourself with PPE, everything, prepare equipments using the STIRA technique, cleanse the chosen area using antiseptic, povidone iodine, and then drip the STIRA field, and then anesthetize the skin, subcutaneous tissue, and also periosteum using the lidocaine just now. And then it is not done in the video, but it can be done. Make a 3 millimeter skin incision using the scalpel blade, and then and then hold the needle perpendicular to the skin and gently advance it to the periosteum. Once it is in the periosteum, point the needle towards the anterior iliac crest. That's why we need to palpate the anterior iliac crest just now, because we need to point it towards the anterior iliac crest. And then using a twisting back and forth motion, just like what was done in the video, advance it into the marrow cavity. So how do we know it's in the marrow cavity? There'll be a give sensation because the marrow is softer, and so that's how we know it's already in the marrow. And then maybe patient complain of a deep-seated pain. And then once there, we need to remove the stylet. You can see just now the needle has 2 parts, the stylet and also the needle. And then attach a syringe and aspirate about 0.2 to 0.5 ml of marrow content. So just a little. And then remove the needle using the same twisting motion, just like what has been shown in the video also. So this is for aspiration only. So for biopsy, if the patient needs biopsy, again, prepare the biopsy needle and then advance it into the same incision, basically into the same site using twisting motion until it is firmly lodged in the bone. So, and then after that, we remove the stylet again, and then we need to advance the needle another 15 to 20 millimeter because we need to get a tissue sample. Yes, after we had advanced it, then we need to basically move the needle a bit and rotate it 360 degree in both directions because we want to detach the tissue so that it won't be left inside after if we pull it out. So, and then remove the needle and then put the tissue biopsy in the formalin solution. And then after all the procedure is done, of course, we need to put a pressure dressing, and also patient should lie supine for at least 10 to 15 minutes. Okay, so there are a few complications for this procedure. First, bleeding. However, bleeding is usually very, very minor, and a pressure dressing is usually helpful to stop the bleeding. Or actually, I forgot to mention just now. For patient that is on antiplatelet, usually, as I read, it is not necessary to stop the medication just to do this procedure because the bleeding is usually very minor, and the pressure dressing will help. So it is more risky to stop the drug. Then we just do this procedure and expect bleeding because the bleeding is usually very, very minor. Okay, and then complication, infection, because we put a foreign body inside our body, and then tumor seeding, because if there is already tumor in the bone marrow and we are pulling it out, so maybe that will cause a tumor seeding along the way. And then needle breakage, but I think this is very rare. And then persistent comfort at biopsy site, even after maybe a few days, the patient will complain. Okay, so that's all from me.
Okay. Yeah. CPR.
Okay, Bismillahirrahmanirrahim. Assalamualaikum everyone. Today I'm going to present about CPR in children. Next. Okay, so basically CPR actually stands for cardiopulmonary resuscitation. So actually CPR is the BLS, the basic life support that we have learned during our emergency posting actually. So the definition is the manual application of the artificial respiration, either mouth to mouth or using belt valve mask and chest compressions to patients in cardiorespiratory arrest. So actually key for successful resuscitation is actually the chain of survival ni lah. Actually, to simplify everything, actually we need to recognize early so that we can do intervention early. So recognize early and call for help, early CPR, early defibrillation. Okay, next. So the indications to do CPR or basic life support is majority due to respiratory insufficiency, which leads to respiratory failure. However, in children, usually cardiac causes is not the main causes. Usually it is caused by asphyxia due to trauma, drowning and poisoning, and then anaphylaxis, which leads to shock, anaphylactic shock. Okay, next. So basically these are the components that we have learned before, DRS, ABCD. So D stands for danger, R for responsiveness, S for shouting for help, A for airway, secure the airway, and B, we check whether the patient is breathing, and then C, the circulation, which consists of checking the pulse, whether the patient has signs of life, and then also chest compression, and also D for defibrillation. Okay, next. So the first step is D, stands for danger. We must ensure that it is safe for us, the healthcare worker, to help the patient. So look for any blood, spills or sharp electric wires surrounding the patient. And then we must also wear PPE if available, personal protective equipment such as gloves, apron, and mask. And then R stands for responsiveness. We must check the child for any response by gently stimulating the child and ask, hello, are you all right? Call the name. And then S stands for shouting for help. Emergency, emergency. And then the instruction must be clear and you must appoint or direct someone specifically to aid you. For example, you call 999. You bring the resuscitation trolley. Okay, next. And then A stands for airway, in which we must secure the airway. In children, we perform head tilt chin lift, in which you place your hand on his forehead and then gently tilt his head back. And then with your fingertips, on the other hand, under the point of child's chin, lift the chin. And then do not push on the soft tissues because it may block the airway. However, if it is still difficult for you to attain a pattern airway, we must do jaw thrust method by placing our fingers of each hand behind child's mandible and push forward. Okay, next. So B stands for breathing, in which we use this principle of look, listen, and feel. So look, we may look for chest movement, and then listen for any breath sounds, and then feel for the air movement on your cheek. You can see how we may perform it by looking at the picture below. So basically all this must be performed in 10 seconds, including the airway. And then what we want to look for is we look for abnormal breathing sounds such as wheezing and then gasping or loss of breath sounds. So if there is respiratory failure, we might provide 5 rescue breaths, in which we may preferably use back valve mask if possible. However, if it is not possible for you to attain back valve mask, you may use mouth to mouth, in which you must ensure the head tilt chin lift is maintained, and then pinch the soft part of the nose with index finger and thumb of your hand on his forehead, and then take a breath and place your lips around his mouth and seal your mouth to the child's mouth, and then blow steadily over 1 second and make the chest rise visible. And then after that, take your mouth away and watch the chest fall. We must ensure that there is no overventilation of the patient. Okay, next. And then C stands for circulation, in which we must do this simultaneously with breathing within 10 seconds. What we want to do is look for any signs of life, such as coughing, normal breathing, and then check the pulse, either from the carotid or femoral pulse. And then you may start chest compression if the pulse is less than 60 beats per minute, with poor perfusion, such as if you see the patient is pale, or if there is irregular or bounding pulse, weak or absent pulse, and then if there is no signs of life, like I've mentioned before. So the characteristics of high quality chest compression, I will explain later. But when do you stop compression is when the child shows signs of life and the help arrives or you become exhausted. Okay, next. So these are the characteristics of high quality chest compression, in which the principle is push hard and push fast to imitate the heart function. allow full chest recoil after each compression, minimize interruption, in which later on we may do defibrillation to shock the patient. So the pre and post shock pauses must be less than 10 seconds, and then avoid excessive ventilation. So the rate of compression is equivalent to the usual heart rate, which is 100 to 120 compressions per minute. The rate of compression to ventilation, if there is only one rescuer, must be 30 to 2 ventilation. If there is 2 rescuers, each may do 15 chest compressions to 2 ventilations. And then the location must be at the lowest sternum, in which first you may locate the xiphisternum first. And then 1 figure breath above the xiphisternum, that is where you want to push to do the chest compression. And then the depth must be 1/3 of the depth of the chest, or 5 centimeter. And then the technique, it is according to the size or the age of the patient actually. So first you may position yourself vertically above the child's chest with both arms remain straight. And then if there is smaller or younger child, use only one hand, heel of one hand, and then you must ensure that the fingers are lifted to avoid pressuring the surrounding ribs. And then if it is largest size or older patients, you may use both hands with fingers interlocked as we did in adult. And then for ventilation, we may use back valve mask, which is much more preferred because according to the latest guideline, positive pressure ventilation is much preferred, and it will reduce disease transmission. And then we may also use mouth to mouth if there is no back valve mask available. And then if there is face shield or pocket mask, you can do it. You can use it also. Okay, next. So this, the left-sided one is actually the pocket mask, and then the right-sided one is actually the back valve mask. Okay, this is how you use it. Okay, next. Okay, the last one is D, which stands for defibrillator. Okay, if there is ECG around, you may also assess the need to shock, in which the shockable rhythm. Shockable rhythm is ventricular fibrillation or pulseless VT, right? And then it can be done via 2 methods. Either AED, automated external defibrillator, or manual defibrillator. If you use AED, just follow the AED voice instruction. And then if you use manual defibrillator, you may select the largest possible size of pedals. If the children, you estimate that the weight is less than 10 kilograms, you may use 4.5 centimeter diameter of pedal. If the children is more than 10 kilogram or older than 1 year, you may use 8 to 12 centimeter diameter. And you must always remember that do not interrupt the chest compression as much as possible, and then immediately continue CPR once done. The chest compression once done. Okay, next. Okay, so this is the video.
Today, we're going to review BLS for the healthcare provider, for the pediatric patient, for the child. Let's take a look at those skill steps now. First, establish unresponsiveness. Next, look for breathing for about 5 seconds. If this child is not breathing, immediately call a code, get some help coming. Now, in healthcare provider, 2 rescuer BLS for the child, our compression to ventilation ratio is 15 to 2. You're going to provide 15 compressions, then provide 2 ventilations of air. We're still going to attach this child to an AED to see maybe if they are in a shockable rhythm. Let's take a look and see what those skills look like, shall we? Hey kid, you okay? Kid's unresponsive. He's not breathing. Nurse, call a code. Hey, this kid doesn't have a pulse. Hey, get over here with that AED. I'm starting compressions. And go right to 15 to 2.
Place electrode.
The EED's here.
Place electrode. Place electrode. Do not touch patient. Analyzing rhythm. Do not touch patient. Analyzing rhythm. Check pulse. If no pulse, give CPR.
Kid's got no pulse.
Okay. Okay, next. Okay, so finally, if the child started to recover or the airway is clear, you may put the patient in recovery position. This is the recovery position guide, in which our goal is to put the child on true lateral position, because it may enable drainage of fluid from mouth if there is any. And then we must ensure that there is no pressure of the chest that impairs breathing, and you must also ensure that the child is as comfortable as possible. Okay, and then for complications, usually if the chest compression or the BLS is properly done, usually no complications. However, certain complications such as gastric distension may arise, especially if you over ventilate the patient, aspiration, and then rib or sternal fracture. However, this is usually occur in elderly, less in children, because children has a relatively more flexible bone. And then lung injuries such as pneumothorax, hemothorax, and also abdominal organ injuries, all this because of over compression of the chest. Okay, I think that's all from me. Thank you.
So I will continue with the CPR in infant. So basically, most of it is pretty much
Did
the
you guys
same.
have, sorry, Aisha, you guys have a neonatal resuscitation later on, right?
We have class. We already have class with Dr. Mosai.
For neonatal resuscitation, because it's
Yes.
slightly different, because I don't want you guys to get confused.
We already
Okay.
have class with.
Okay, fine.
Okay. Right. Okay. So basically, as mentioned before, CPR is the cardiopulmonary resuscitation. So which is an emergency life-saving procedure, which consists of the chest compression as well as the artificial ventilation. So, and it is a part of basic life support. So in children, the primary respiratory arrest is more common than primary cardiac arrest to happen. So when cardiac arrest is typically the end result of deterioration in respiratory function or shock. So basically for infant, the age is from 1 month to 1 year of age. So the indication to do CPR in infant is when there is cardiorespiratory arrest, as well as when there is bradycardia, which is the heart rate is less than 60 beats per minute with poor perfusion. Next. So these are the equipments needed, which are the PPE, back valve mask, and then the AED. Next. So the technique is similar as CPR in children. So whereby we identify if there is any danger to ensure our safety, our own safety, as well as the infant. And then by wearing PPE, look out for any blood spill, sharp electric wires. And then for the responsiveness, we check by gently stimulate the infant. For example, by tapping the infant's foot and then speak loudly to see if there is any response. And then if we suspect the infant to have cervical spine injury, we must not shake the infant. And then if the infant does not respond, then we shout for help as quickly as possible. And then we assess the airway. So but we assess the airway of the infant by turning them onto their back and then open the airway by using the head, tail, and chin lift. And if we still have difficulty in opening the airway, we use the jaw thrust method. Okay, next. So and then we assess the breathing by putting our face close to the infant's face, and then we do the look, listen, and feel. So and then for the look, we look for chest movement, and then listen at the nose and mouth for breath sounds, and then we feel for any air movement on our cheek. And then if there is normal breathing, we turn the infant into recovery position, and then we send them or go for help. And then if there is if the breathing is not normal or absent, so we started to give them the 5 initial rescue breath. Okay, either by mouth to mouth or back valve mask. And then we move to the circulation or compression. So we assess the circulation. We should assess the circulation not more than 10 seconds. Now we have to look for signs of life such as movement, coughing, and normal breathing. Now we feel for the pulse. Usually we feel the pulse at the brachial, which is at the inner aspect of the upper arm, or we can also feel for the femoral pulse. Then if there are no signs of life, we should start chest compressions. So we place our fingers on the lower half of the sternum, and then the depth should be at least 1/3 of the chest or 4 centimeter. And then the rate is 100 to 120 beats per minute. And then we have to allow full recoil of the chest after each chest compression. And then for the ratio, we after 15 compression, we give 2 effective breath. Okay. Next. So there are 2 techniques that we can use for the chest compression, which either 2 fingers technique or encircling technique. So 2 fingers technique is used when there is only single rescuer. So 2 finger techniques is done by compressing the sternum with the tips of 2 fingers. And then for the encircling technique, it is done when there are 2 or more rescuer. So in this technique, we place both thumbs flat side by side on the lower half of the sternum, and then the other finger we encircle the lower part of the rib cage to support the infant's back. And then we compress the chest with both of our thumbs. And then next is the defibrillation, which is we need to assess whether the patient needs to shock or not. And then lastly is the recovery position, which is an unconscious infant with clear airway and breathing normally should be turned onto the side into the recovery position. So the important principle that we need to know is that we have to place the infant in as near as true lateral position to enable the drainage of fluid from the mouth. And then we have to ensure the position is stable by putting a small pillow or roll up blanket behind the infant to maintain the position, and then make sure there is no pressure on the chest that can impair the breathing, as well as ensure airway is accessible and easily observed. Okay, next. Next is the video. There might be some different, okay, for example.
What we're going to teach today is how to do infant CPR or cardiopulmonary resuscitation. Once you've assessed that the infant is not breathing and is not alert and awake, you need to call for help. That's very important. Remove any clothing that the child may have on. You'll want to put your fingers right in the inner aspect of the arm and feel for a pulse. You should only feel for a pulse for 5 to 10 seconds. Make sure that the infant is on a flat surface as much as possible and a hard surface. You'll want to take your 2 fingers, your index finger and your middle finger, and place it right in the middle of the breastbone or the sternum underneath the 2 nipple lines. And you'll want to begin compressions, pushing down on the chest and allowing the chest to come up, down on the chest, up, down on the chest, up. And you want to do this for 30 beats. So 1, 2, 3, 4, 5. Don't worry, you're not going to push too hard, I promise. So you push hard enough And you do that for 30 beats. After you've done the 30 chest compressions, you'll then move quickly to the head of the baby and you will want to give rescue breaths. The first thing you want to do is tilt the head back and lift the chin up so that you open up the airway. You'll then pinch the nose with one hand and you will deliver a rescue breath over 1 second. And you should have sufficient air blowing into the baby to see both of the chest walls rise like this. And you'll want to do that twice. So you do 30 chest compressions and you give 2 rescue breaths. Immediately when you finish the 2 rescue breaths, you go back to doing chest compressions. If you are the only person there, then you start chest compressions and rescue breaths for 2 minutes, and then you need to leave the side of the infant and call 911 for help. What we're going to teach today is how to do infants.
Okay, so these are the complications from the CPR that might happen. But as mentioned by Nurin before, if usually if the CPR is done properly and correctly, there will be no complication. So the complication can be rib fractures, pneumothorax, hemorrhage, and aspiration. So I think that's all from us.
Okay. Any questions? Don't have, then okay lah. I'll send you your. I'll send Farah in the office your marks, okay? Oh.
Okay, doctor.
Okay. Wait. You guys. Do I have any baseline teaching with you guys? Do I have baseline teaching with you guys after this? Tak ada lah kan?
Tak ada.
Tak ada. Okay. Okay, bye-bye.
Okay, thank you, doctor.
Welcome.